When predicting a patient's 5-year risk of developing late age-related macular degeneration, the statistical danger doesn't climb on a gentle slope, severity score on the horizontal axis, against the precise event rate of developing late AMD on the vertical axis. Starting at the far left, a severity score of 0 corresponds to a negligible 0.5% risk over 5 years. Compare that to the extreme upper bound. A patient's severity score of 4 translates to a 50% chance, a literal coin flip, that the patient will develop late-stage disease within that same 5-year window. Managing AMD risk, therefore, comes down to a specialist's ability to accurately evaluate physical changes in the eye and map those phenotypes directly to these abstract severity scores. We often tell patients to monitor their own vision at home, using tools like Amsler grids for daily or weekly checks. But these methods have a built-in flaw. They are notoriously unreliable at pinpointing the exact onset of neovascular, or wet, AMD. By the time a patient notices a visual distortion, the pathophysiology is already advanced. That failure rate makes rigorous in-office clinical diagnostics absolutely mandatory. We have to catch the microscopic structural shifts before they cause irreversible damage. To do that, we need to categorize the exact subretinal biomarkers that inform the patient's severity score. We are going to link the anatomy of the eye directly to statistical risk, translating that data into actionable clinical review schedules. The primary physical biomarker driving this severity score is the accumulation of drusen. Drusen is lipoprotein material. Pathologically, it deposits strictly between the retinal pigment epithelium, the RPE, and Bruch's membrane. But we don't look everywhere. For clinical assessment, we adhere to a strict horizontal boundary, examining the area exactly within 2 disc diameters of the central fovea. A reliable clinical trick to estimate this exact boundary in practice is to use the width of a vein at the optic disc edge as a standard unit of measurement. If this lipoprotein material accumulates outside of that specific 2 disc diameter zone, it does not heavily factor into the patient's primary severity score. Identifying and measuring this specific anatomical disruption, strictly within this geographical boundary, forms the entire foundation of our AMD risk stratification. Returning to this chart, look at the 0 column. This represents our lowest risk tier, with a baseline 0.4 to 0.5% chance of progression. To place a patient in this tier, they must present with only small drusen. Crucially, they must also show an absolute lack of any pigmentary changes. For a patient with this specific presentation, the standard clinical protocol requires a routine 1 to 2 year review schedule. Small drusen without pigmentary disruption is a stable subretinal baseline. At this stage, the eye requires monitoring, not medical intervention. Now look at the far right of the chart. This is the extreme end of the clinical spectrum, marked by a critical 50% progression risk over 5 years. The primary physical marker driving this extreme risk is a shift in size. The patient now presents with large drusen, appearing bilaterally in both eyes. The secondary factor that pushes this probability to a coin flip is the presence of bilateral pigmentary changes. This high-risk phenotype demands immediate attention. The review schedule for these patients tightens to a strict 3-month interval. Watch how the risk changes when we remove just one element of bilaterality. Here is the mid-tier risk, presenting a 25% chance of progression. In this presentation, the patient still has bilateral large drusen. However, the pigmentary changes are only unilateral. That slight reduction in bilaterality halves the statistical risk, which relaxes our review schedule from 3 months to every 6 months. The primary driver of AMD risk is the combination of drusen size paired with the bilaterality of those pigmentary changes. Accurately logging these changes relies on high-quality imaging because standard funduscopy is often insufficient for verifying the true nature of subretinal deposits. A major diagnostic pitfall is confusing true drusen with reticular pseudodrusen. Mistaking one for the other will completely skew your calculation of the severity score. To accurately differentiate between the two, clinicians must rely on optical coherence tomography, or OCT, and near-infrared imaging. If OCT is unavailable, the standard clinical fallback protocol dictates the use of a red-free filter. Without utilizing specific diagnostic filters to confirm the presence of true drusen, assigning an accurate severity score is impossible and medically irresponsible. This stratification is designed to detect the transition from dry AMD into neovascular macular formation. The first major signs of this escalation are subretinal fluid and the physical lifting of the RPE, a pigment epithelial detachment. We confirm this with a strict threshold. If central foveal thickness measures greater than 100 micrometers, the disease has progressed. OCT angiography is specifically used to explicitly visualize the invasive neovascular network that has broken through. The appearance of these specific anatomical markers definitively shifts the patient's status. They are no longer in passive monitoring, they require active disease management. Before discussing immediate triage, we need to clarify a common clinical misconception. Nutritional supplements are strictly indicated for intermediate and late-stage AMD. They are not prescribed for early stages. Once neovascular AMD is confirmed and symptomatic, it triggers an urgent triage pathway. The patient requires an immediate referral within 1 week for anti-VEGF therapy. The initial injection schedule for drugs like Eylea or ranibizumab is strictly monthly for the first 3 months. After that initial period, the frequency can vary based on the patient's response. If the neovascular AMD is an incidental, completely asymptomatic finding on an OCT scan, the secondary triage pathway extends that referral window slightly to within 2 weeks. Finally, patients presenting with geographic atrophy follow a tertiary pathway. They require a non-urgent referral to ophthalmology or low-vision support groups. Identifying subretinal anatomy provides the necessary foundation for mathematical risk stratification. This data dictates the treatment timeline required to preserve a patient's vision.